Hello, I'm Stephen Marwaha. I'm a professor of psychiatry at the University of Birmingham, and I'm also a consultant psychiatrist in Birmingham and Solihull Mental Health Trust, where I run a specialist mood disorders clinic. And it's a great pleasure to be talking about early intervention for bipolar disorder today at this conference. And I'm going to be focused on why early intervention, for whom, and some of the challenges really that have been talked about in the literature, and also the concerns of clinicians or people with bipolar disorder themselves may have about this approach. So by conflicts of interest, there's my list. Okay, so this subject isn't new. Myself and a number of colleagues from the Midlands, including Matthew Broom and Rachel Upthegrove and Andy Thompson, wrote this editorial about 5 or 6 years ago talking about the progress of early intervention in psychosis, but also highlighting how the approach might take effect in other types of disorders. So I'm sure nearly everybody in the audience knows what bipolar disorder is, but just in case there's any misunderstanding, bipolar disorders are characterised by recurrent episodes of elevated mood and episodes of depression, although about 30% of episodes are actually mixed affective episodes. So it's a multi-component disorder with impacts or etiology linked to the brain, as you might expect, gut, infections, or the inflammatory system. And by and large, it has an impact on mood, activity, sleep, thinking, and behaviour. So the key questions for early interventions, and I don't think these are the only ones, but these are the pretty important ones at least. So does the nature of the condition warrant that early intervention is going to be worthwhile? Secondly, is treatment more effective earlier in illness course? Thirdly, can we really identify people who are going to develop bipolar disorder, and how accurately can we identify them, and can we intervene? And finally, what's the optimal treatment package really for an individual with first episode bipolar disorder to try to reduce further morbidity, and where to provide that treatment? So these are the questions I'm really going to be looking at today, and trying to provide a kind of summary of the literature to date in that particular question or field. So does the nature of the disorder really warrant worthwhile? Well, bipolar disorder is a common severe mental illness. So the worldwide prevalence rate is about 2.4%. So the bulk of that 1.4% is subthreshold bipolar disorders, but it's a pretty common. Secondly, it causes a very high global burden of disease in 10 to 24-year-olds. So you'll see in the final column there, it's fourth in this list, marginally pipped to the third position by schizophrenia. It's also very costly in human terms as well as financial terms, so there's a high rate of premature death. Costs in the UK in 2010 prices was £5.2 billion a year. Clearly the global costs are huge, and in part that's because of relapse rates in the condition are so. It's also related not necessarily to direct costs of the condition, but indirect costs to the individual and society. So although we found in this review about 60% of people with bipolar disorder were working, if you looked at the data, there was a general downward drift over time in the kinds of work that people were doing in comparison to what you might predict they were doing. And finally, being absent from work or poor work performance is particularly common in people with bipolar. Also, the age of onset is really very young, 10 to 24-year-olds, 15 to 25-year-olds being the peak incident. And I know that cognitive impairments or cognitive difficulties in bipolar disorder is a fairly contentious field, but there is some evidence, although it is contested, I should say, that the more episodes you get, the greater difficulties there are in cognition. And that's basically really important because it's strongly connected to your functional capacity. So more cognitive difficulties, greater deficits in your functioning, so functioning in relationships. We're also not terribly good at diagnosing the disorder very early or promptly. So on average, it takes about 12 years to diagnose the disorder from the first onset of mood symptoms in childhood or late adolescence. And that's pretty important because during that time, people are either getting poor treatment or basically incorrect or harmful treatment. So secondly, is treatment more effective earlier in illness course? So I'm not going to go over this in very much detail because it's the subject of an ISBD Taskforce report which should be coming out soon. And I'm co-chair alongside colleagues in Australia on that Taskforce report. I looked at the literature previously in about 5 years ago, considering earlier. And if you looked at a wide variety of trials and also a meta-analysis, whatever type of treatment you're talking about, whether medicine or psychoeducation or other psychological treatment, and you also looked at a range of outcomes, there does appear to be a fairly consistent signal that earlier treatment is more effective than the same treatment given in people who have had multiple episodes. Now, that obviously does have some methodological difficulties because, in effect, the comparison group are people with a few episodes and people with multiple episodes. And so people with multiple episodes, by definition, to some extent are treatment resistant. So there is some confounding there. But overall, there does appear to be a effect. So can we identify people who are going to develop bipolar disorder and do? So this was the subject of another ISBD task force report by many learned and clever colleagues here. So I think this is a major challenge. A lovely paper, but major challenge because in essence we don't know the developmental trajectory for the majority of people with bipolar disorder. And that's not a difficulty with bipolar disorder per se, although it is a pretty heterogeneous condition. It's because we don't know the developmental course for many mental disorders. So it's a tough. So in this report, people suggested that there were heterotypic and homotypic factors that might be associated with people developing the disorder. And heterotypic factors present a real challenge because they are factors which are associated with onset of the disorder, but to some extent the connection is quite murky. And what I mean by that is that we're really not that clear about the accuracy of each individual of the symptoms and their predictability in being clinically helpful, really, to understand who's going to develop the disorder. So it's things like borderline personality disorder, anxiety syndromes, childhood ADHD. And I'm just going to give you a difficulty. So this is some work done by my PhD student Buse Durdurak, who's looked at data, so doing a very large meta-review, looking at papers examining emerging borderline personality disorder and emerging bipolar disorder to see if there's definitive or distinctive factors in this condition. The reason we picked this because in the clinical world, well, this is one of the commonest referrals I get in my clinic for young people. Does this person have emerging borderline personality disorder or do they have emerging bipolar disorder? And you can see there is a lot of commonality in some of these factors for both disorders. So suicidality, family psychopathology, substance misuse, affective instability and anxiety, etc. So there are some factors that only appear to be evident in bipolar disorder studies. So these are subsyndromal hypomania, cyclothymic disorder, frequency and loading of affective symptoms. And I will briefly talk about those. And there are also some apparently definitive symptoms that might be in borderline personality disorder, such as attachment problems, impulsivity, dissociation, or oppositional defiance. But the point I'm making here is it's a murky area. So that's similarly the case in terms of diagnostic uncertainty and comorbidity with ADHD. So 5 to 20% of adults have the condition, no matter which you consider as the primary. In children and young people, the rate of comorbidity is higher. Mood, and you can see why that might be, because there's some overlapping symptoms to some extent, maybe labelled differently, but the core symptom is probably the same. Mood instability is obviously also common in emerging bipolar disorder, but it's actually very common in people with ADHD, even though it isn't part of the area. And so we know that in children with ADHD, a proportion are at higher risk of developing bipolar disorder. At an individual level, how much risk that entails. So there are, according to the Taskforce report, there are also homotypic factors, and these are really subsyndromal bipolar disorder symptoms, such as mood lability, attenuated manic-like symptoms, racing thoughts, decreased need for sleep, or even frank hypomania. So the kind of symptoms you might expect in someone who actually has the condition, but at a form. And so, of course, there is some cause to look at a prodrome. So this is obviously usually defined in retrospect, but you can use prodromal features to try to identify individually. So in this, what I think is a kind of leading study in this area, Andreas Besthoff and colleagues compared people who were bipolar at-risk criteria positive, so often subsyndromal manic symptoms and the age of risk, and they compared that group with people who didn't score as having at-risk criteria of bipolar disorder, and followed them up for over a year. And at that year point, they found that about 14% of people who they were classified as at risk of bipolar disorder actually developed the condition, whereas nobody in the non-risk group developed the disorder. So that, on the face of it, is pretty good. So if you compare that with diabetes, the transition rate from pre-diabetes to diabetes over 1 year is about 9 to 10%. So this is a pretty strong signal. The issue, of course, here is that about 85% of people who were classified as at risk of bipolar disorder didn't develop the condition. So it's certainly a strong signal, but you end up asking the question, how far are we going to be able to use this clinically? Obviously, people do use this clinically because the 85% of people who don't develop bipolar disorder aren't necessarily well. But it does give you some idea of the challenge here. So Jan Scott, with myself and a number of other colleagues, looked at the bipolar at-risk criteria also, and we found that cyclothymia showed the optimal profile for case finding, screening in research settings, so really good clinical rule-in accuracy and clinical rule-out accuracy. So overall, cyclothymia was the thing that seemed most promising, but the problem was it's only really recorded in 50% of case notes. And I think even people in the field sometimes have some difficulty in really describing what cyclothymia is. And there is also a good deal of clinical lack of clarity on how you go about assigning someone with a diagnosis of cyclothymia. So, might an individual risk calculator be part of the solution? So these are examples of prediction modelling, really. So the probably the most well-known risk calculator is the Q risk calculator, and that gives you a measure of risk of a future cardiovascular event if you have by assessing features such as blood pressure, cholesterol, your age, your gender, and ethnicity. So could we use that kind of idea to decipher an individual risk? And this group, based at Pittsburgh and I think Brown University and the University of California, this is one of 3 risk calculators that they've developed. So they used data from 140 young people who had bipolar disorder not otherwise specified. So that's probably a group of people who have some syndrome or symptoms, and they followed them up over a period of time, and they built a risk calculator based on risks that they had found in the literature of the risk of conversion. And they did do some external validation, but the external validation of the risk calculator was from a sample. The great news was that they found that earlier onset bipolar disorder, not otherwise specified, familial hypomania, higher mania, anxiety, mood lability symptoms were really important predictors in their risk calculator, and their risk calculator had a pretty good area under the curve, so 0.71. So one measure of how effective a risk calculator is area under the curve, and the Q risk score has an area under the curve of above 0.8. 0.5, your risk calculator is no better than chance. 1 is perfect prediction at an individual level. So 0.7, this is pretty good. So it's a really lovely piece of science. The same group have also produced a risk calculator to look at risk of onset of bipolar disorder in young people who are at familial risk, and you can have a look at this on their web page, and it's the similar kind of symptoms that they've used, and this one needs some external. So obviously the beauty of these risk calculators is that you can tell an individual what their risk may be of developing the disorder by combining the risk of individual factors within a model. So if we're able to identify some people who may be at increased risk, what should we do about it? And this systematic review of clinical trials was published not so long ago. So the primary outcomes that they found in trials were really a change in manic and depressive symptoms from baseline to endpoint. They found 16 studies. Many of those, the majority of those were for psychological treatments and 5 for pharmacological. So in summary, I think the first important point is that reducing the risk of conversion to bipolar disorder, which I would have thought is one of the most important outcomes, there really isn't a lot of data on that in these trials. So they found no evidence for the use of valproate or lithium, some evidence for aripiprazole and quetiapine, although you obviously have to consider the side effect profile and ethics of using antipsychotics in this group. They did find evidence for family psychoeducation, psychotherapy, interpersonal and social rhythm therapy. But you also have to consider the availability of these treatments, certainly in the NHS, and the skill levels of therapists who are around to deliver this treatment. So what is the optimal treatment in the early course, and where? So alongside colleagues, we've reviewed quite a few guidelines, actually 14 international and national guidelines, to look for evidence of what those guidelines recommend in terms of the treatment of early stage of the disorder. So by early stage meaning after the first episode, the first few episodes after the first episode. So there was really no consistent guidelines for this group of people. There was some summary of recommendations for adolescents, which by default, I guess, to some extent covers this population that we're talking about. So for mania, the recommendations were aripiprazole, lithium, olanzapine and quetiapine. Bipolar depression, adjunctive pharmacotherapy, psychosocial interventions, lamotrigine, aspects also in terms of psychological treatment such as psychoeducation, CBT, family-focused therapy, interpersonal therapy, social rhythm therapy. So quite a lot of that, I think, is as you would expect, and I think it probably shows to some extent the lack of specific trials. So one of the few specific trials of a care package, because obviously we don't treat people just with medicine or just with psychoeducational or psychological treatments. There's normally a whole care package you would want to provide for people. So this is one of the few trials that exist in this space, and I mean, I've been trying to repeat something like this by getting grant funding over the last 3 or 4 years, but not managed to get that so far. A really lovely study by Lars Kessing et al. Comparing specialist treatment for people with bipolar disorder after their first, second or third hospital discharge with mania or bipolar disorder, comparing it to treatment as usual by and large. So the intervention it's worthwhile saying a little bit about. So this was specialised outpatient treatment. There was a multidisciplinary team, so a lot of expertise in bipolar disorder, and evidence-based pharmacological treatment and group psychoeducation. And I gather the pharmacological treatment was based on, to some extent, the British Association of Psychopharmacology guidelines. So what they did was they followed people up over a prolonged period of time, 2, 3, 4, 5 years, and they found that the absolute rate of readmission in people who received the specialist treatment was about 26 in comparison to 48. So that in percentage terms, that 36% relapse versus 55% relapse, and this was statistically. And as you might expect, the treatment for a specialist mood disorders clinic is more expensive than treatment as usual, but just like the early intervention services for psychosis world, early intervention for bipolar disorder appeared to be cost effective. Saving. So where should we provide some of this treatment? And I think this is a slightly tricky area. So Samir and colleagues have published this really lovely personal view reviewing the data on the treatment for first episode mania, and they conclude that first episode mania should be by and large be treated in early intervention services. So I don't think I'm speaking out of turn in saying that there's actually some variation, at least in the UK, in the extent to which people with bipolar disorder are accepted into early intervention services. We also know from a START survey that I've done of people working in early intervention services that those EI teams vary in the extent to which they offer bipolar disorder specific treatment. So do manic symptoms within early intervention services in people with first episode psychosis have an impact on their remission? So this is data that we've published from the National Eden study, which is a longitudinal cohort of people admitted to early intervention services in the UK and followed up over a period of time. And we compared about 240 people with manic symptoms who had first episode psychosis versus about 640 people without manic symptoms. Now, obviously, manic symptoms doesn't mean people have bipolar disorder, but it is a measure of bipolarity in phases. So firstly, importantly, we found that the duration of untreated illness was significantly longer in people with manic symptoms. So maybe that's because these symptoms are being attributed to drugs perhaps, or the individuals themselves don't necessarily think that manic symptoms need intervention, so that's pretty common, certainly in hypomania. Or it may be that clinicians themselves are less attuned to this group. So the estimated median time to reach remission was about 120 days if you had manic symptoms, in comparison to about 90 days if you didn't have manic symptoms. So the kind of bottom line is, if you have manic symptoms in an early intervention service, it looks like you're taking much longer to get better. And that was the case in an unadjusted analysis, but also an adjusted survival analysis, which looked at confounding for the usual things that you might expect to have an impact on remission. So it does look like manic or perhaps bipolar, or proportion of people with bipolar disorder sitting within early intervention services may need better treatment than they're currently getting. Then bipolar treatment than psychosis treatment. So, can prediction modelling form part of the future of early intervention? Again, because one of the issues may be that we tend to provide standardised treatment for everybody, as opposed to stratifying treatment in early course. So this is the third risk calculator that this group have produced, and I think, to be honest, it's the only 3 risk calculators that have been published in bipolar disorder. We were certainly working on one but didn't get very good results, but we're continuing to work on a slightly different sample to develop a risk calculator for bipolar disorder with. So this risk calculator looked at the risk of recurrence, which is obviously a major event in a young person's life with bipolar disorder, after their first episode. And they found a really good area under the curve again, so about 80%, equivalent to the Q risk score, and a positive predictive value at a particular risk score cutoff, which is about 0.8. So that's a measure of the accuracy of the actual risk calculator itself, so that a measure of the proportion of people who are going to develop the condition who score positive on your risk calculator. And really beautifully with this risk calculator, it doesn't involve genotyping, it doesn't involve polygenic risk scores, it doesn't involve neuroimaging. These are factors that most clinicians and stakeholders in the field would be able to decipher. So shorter prior and current recovery lengths, younger age at assessment, earlier mood onset and more severe prior depression were the strongest factors in their prediction. So for me, individual risk prediction is probably core to early intervention in bipolar disorder, in part because of the heterogeneity of the condition, in part because of the multiple factors that appear to be associated with the onset of this severe mood disorder. So we need to be able to stratify treatment to risk, so people with higher needs obtaining an optimal set of interventions, optimal treatment, whereas people with a lower risk of recurrence perhaps not receiving a whole host of interventions which they may not find credible, actually, may not want, and also are quite resource intensive. So we probably do need much larger samples in these risk calculators, in my view, and they probably need to be international, parts of international consortia, and we need robust external validation. So Rachel Upthegrove, a colleague of mine in Birmingham, tells me that once we've got those calculators, we also need to test those in prospective studies. But for me, we need to test them eventually in randomized control trials, assigning a particular treatment if you're low risk in comparison to treatment as usual, or if you're high risk, to see the value of these individual risk calculators. So I'm going to return to the key questions that I wanted to ask. So does the nature of the condition warrant that early intervention is going to be worthwhile? Well, for my money, and I hope I've convinced you, yes, it basically does. Is treatment more effective earlier in illness course? Well, there's going to be a report coming out soon, but there's certainly a pretty strong signal that it looks like that's the case, although there are some methodological caveats to the data that we've got so far. Can we identify people who will develop bipolar disorder and intervene? Well, I think yes, we can, and with increasing levels of accuracy. And there is some data on how we might go about intervening in that group. Finally, what's the optimal treatment after a first episode to reduce further morbidity or recurrences, and where should we provide that? Well, it looks like a mixture of medication and psychoeducation is the optimal treatment. But for me, this is an area which there's really quite a lot of work to do in terms of being able to stratify treatment, giving the right treatment to the right people at the right time in a way that's going to be effective and acceptable and credible for people. So finally, these are just a couple of references that I haven't identified very clearly in the presentation. And thank you for listening.
Thanks, Stephen. That was a really informing and great talk. And I think you made the case for your arguments very strongly and convincingly. But I'm biased because I'm predisposed to thinking that yes, this should be a focus of early intervention. We have a few questions already, and I would say to people, if you do have questions, please feel free to add them. We've got, I think, 10 or 15 minutes now for some questions. So, Stephen, the first question I've got is from Lucia, and she sort of said, could you comment on the validity of risk calculators for marginalised groups, for example, ethnic minorities?
Thanks very much. So I think the first thing I'd say is that prediction models for bipolar disorder, whatever the kind of population you're looking at, are pretty limited. So overall, my gut instinct is that we don't really know the validity, because we don't, with quite a lot of these samples, as you might imagine, they're not necessarily very super diverse or have multiple ethnic groups in them, at least with large enough numbers that one might begin to think that these models are valid in different kinds of groups. And I think that's partly why I said towards the end of the talk that I think we need much larger samples. I mean, we probably, in my view, need to group together samples from different populations in different countries, really, to build models that we can comfortably say are actually valid in kind of different populations, because they actually have those populations in the kind of initial sampling.
Yeah. So, and I think you made that point in the talk too, didn't you? That you just need to have there's a very strong need for sort of multinational collaborations around this effort.
I think that's true, and I think in part because with psychosis services, I think they're actually very well established in lots of places around the globe in terms of early intervention services. But I think kind of an international collaboration on first episode bipolar disorder is much less clear, and certainly I can only speak the UK context here. Whenever I've applied for such work, I often get comments back, well, where are you really going to recruit from? Mm-hmm. Because there's not a kind of prevailing view that early intervention services, for example, will have the majority of people with first episode bipolar disorder. I mean, they'll certainly have some, and I think that's an issue for international collaborations in this area, really. Mm. Where do people with first episode bipolar present, and To what extent do they present in psychosis services? To what extent do they present in mood disorder services? Because I think there's a lot of, there's just a lot of difference between countries, really.
Yeah, it does make me wonder, and I'm going to get to there's other questions at the moment, so I'm not going to hog the entire thing, but it makes me wonder about the potential of large-scale primary mental health care platforms like we have in Australia with Headspace, where I imagine you might get people presenting quite early in the course of things. And I don't know whether there's been thought about using platforms like that to explore those questions.
Yes, I mean, I think that's probably correct, that we need primary care data or primary care level of services, around the globe, really, because I think lots of people essentially present with mood swings very often. Yeah. And certainly, actually, my own sense from where I practice is that young people are very cognizant and concerned, actually, if they have mood swings, that they may have bipolar disorder. But there's just a very high threshold to get through the door to get a kind of assessment. And it's not a diagnosis that primary care physicians are very keen to make, really.
Yeah. On to some questions by other people. This is from Nuno Madeira, pardon me, who said, excellent talk. A question, would you consider different treatment options, preferences, when treating clinical depression in young people at risk for bipolar disorder? For example, family history, risk calcula estimations, etc.
Yes, thanks for that question, So I think that's one of the most powerful reasons to develop risk calculators for people at risk of bipolar disorder. So I think I put up a slide, the long delay between first presentation of symptoms and actually getting a diagnosis and possibly optimal treatment. And in that time, I think people are often clinically depressed, but often having other diagnoses attached to their clinical depression. And although I don't think there's absolute clarity, I think you probably want to avoid giving antidepressants to people that you think were going to imminently develop bipolar disorder, because you might increase mood instability or kind of make the onset of the condition closer to where you are now. So, reduce the delay in the onset. So that's a very good reason to be able to identify people who are at risk, because you also might want to offer people with clinical depression a modified psychological intervention, which looks at mood regulation much more than standard CBT, for example, or emotional skills training. So I think there are good reasons to want to know who's at risk. And I think that is because you would probably at least consider with them whether you wanted to treat them in a different way.
So we also have a question from Anthony Pelosi in Glasgow, who has said, Professor Marwaha, thanks for this very clear and very thoughtful talk. You are right to feel a bit daunted by clinical issues that making prediction of bipolar disorder problematic. Could you comment on what I think is a much greater challenge, namely that the positive predictive value of any test is prevalence dependent? I reckon that this problem swamps all of the other concerns that you and your colleagues are grappling with. Any thoughts?
Yes, so that's true. And that is why I have really focused towards the end on prediction modeling, where the PPV is really rather high at about 0.8. I think if you're looking at individual symptoms, then that really is a very difficult situation. But I think that's why, to some extent, prediction modeling gets over that. So, I mean, it's a very live issue. I've tried to be very sanguine with the kind of prediction stuff, because I know it's a really contentious area within bipolar disorder, no doubt. And I think there are very different views. But I'm also not of the group of people who are fairly nihilistic about not wanting to kind of attempt to do this, because I think it's too important a clinical problem, really, to not to try to grapple with this.
Yeah, and there's a need to try something, isn't there? And to see if you can do any kind of prediction, and we can only get better by starting somewhere. So
yeah, so that's my view as well, that it doesn't need to be perfect to start off with, as long as we're straight with the people we're trying to provide care for.
That's right. Yeah.
So, that's essentially my model of trying to provide care, that I'm very open with what the data is really telling us and what it doesn't really tell us as well. So, I think that's my view. We have to start somewhere, and you build models and then you improve models. Whereas if we say it's just all impossible, then we're not going to get anywhere. I suppose it's my general strategy.
Yeah, no, I completely agree with that. A few more questions coming in. So Marie-Joelle Bedard has asked, do you think uniting first episode psychosis clinics with patients with first bipolar episode, knowing that adolescents with bipolar are more prone to have psychotic symptoms, could be a feasible or favourable possibility?
Yes, I think it's a feasible possibility, no doubt. So, sorry, is your do you think of uniting FEP clinic with patients with? Okay, so I think lots of first episode psychosis clinics do see people with first episode bipolar disorder. I just don't think it's very uniform, and it may be different internationally as well. So I think that is already occurring, and I think it is possible. The data that I have shows that people, I think I presented it, shows that staff themselves aren't always providing a bipolar disorder specific care package. So there may be some issues about confidence or identifying people and being very specific with those people. I do know of some services where there's a named number of clinicians within the first episode psychosis service who just focus on people who are thought to have bipolar disorder pretty early on, and try to discuss mood stabilizers pretty early on. It's a moving field, really. So the data that I presented showed that certainly manic symptoms increase your time to remission within the UK. I mean, that data is from data collected some 5 or 6 years ago now, I think, the end of that data collection. But it did show a clear impact of having manic symptoms. And I'm not saying all those people have bipolar disorder, but it just gives you a signal that maybe care needs to change for that particular group.
Great. Still about 3.5 minutes left, and we've got a couple of questions still here, so we'll see if we can get through them. So Anne-Marie Saint-Germain has asked, which pharmacological option has shown to have the greatest success rate for clients during their first presentation? Do you see a difference between long-acting injectable medications versus oral options?
So with medications, I think that the problem is that international guidelines actually disagree on, or not necessarily disagree, but aren't necessarily consistent for bipolar disorder in this area in terms of adolescence, but also after the first episode. And I do feel like this is washing your dirty laundry in public, but I've looked at international BD guidelines just in general, and there is a good deal of discrepancy between the international guidelines. So I don't know whether that's just something about the field or whether the evidence isn't strong enough for particular agents. I must admit, I don't know a lot about comparative studies between injectable medications versus oral options for people with bipolar disorder, in part because I think the general push is to consider lithium very early on because it's got a very strong evidence base for longer term. So I'm sure, you know, adherence is a problem, you know, for people with bipolar disorder, and I guess that's why for people with psychosis or ease of actually taking the medication, often injectables are suggested. But I'm afraid I don't know too much specifics for bipolar disorder in this population anyway.
Yeah, well, like you say, maybe the evidence still needs to be developed. Do many first episode bipolar cases present after 35 years of age? Richard Whale would like to know.
Yes, I think the epidemiology is that there's a bimodal increased rate of or increased incidence, basically. So the first wave is 20 to 25, or broadly speaking, thereabouts. And then late 40s, early 50s, I think, is the second wave. The second wave is much smaller than the first wave. And I think there is some evidence that it's linked to physical health problems, for example. But I don't think we're completely clear on the second wave. I think there's just much more data on young people developing their condition.
One final question, we're going to slightly over, but I think this is a good question. If you were to get an early intervention for bipolar disorder up and running, would you discharge these patients after 2 or 3 years? And who would you discharge them to? Again, from Anthony Pelosi.
It's a great question because I don't really know the answer. I think where would I discharge them after 2 to 3 years? Well, if funding was unlimited, probably not, because unless they were completely well and wanted to be discharged. Personally, I think people with bipolar disorder are underserved by mental health services in general, and they don't tend to have a terribly good experience in mental health services either. So I personally probably wouldn't. I think the guidelines in the UK, the NICE guidelines, say consider discharging to primary care, where I think that is perfectly possible. But you obviously have to balance longer term interventions with, you know, quick fixes and getting people out of secondary mental health services. Lots of people do want to be discharged, actually, but lots of people, frankly, don't and keep on returning because they become unwell.
I think that sort of speaks to the need for a system that can flex up and down in terms of where people are at and the care they need at any particular time, doesn't it? We'll have to finish there, Stephen. Look, it's been really fantastic. Thank you for your talk and thank you for your responses to these questions. I'd also thank the audience for their questions as well. I think that enlivens any session. Thank you, Stephen. It's been really fantastic. There's going to be a very short break now, and then the next plenary will be happening in the other room. So I'd ask people to access that through the platform, and we'll see you there.